Uh,
No. I have.
yeah. Done, sir, I think.
Okay, so good morning, friends. And today we'll be discussing about fatigues, excessive daytime sleepiness, as well as sleep deprivation. So first, we will try to look whether the sleepiness is pathological or it can just be a physiological need. Then we will look at the neurobiology of sleepiness. Then we will try to differentiate the sleepiness from the fatigue. Then we see how can we assess the sleepiness and the fatigue. Then we will look at the legal aspects of the fatigue, and then we will try to find out how does the recovery sleep help in regaining the functions that are lost because of the sleepiness. So, when we talk about the sleepiness that usually results from the inadequate amount of the sleep, and we all know that the sleep is regulated by the two process model. One is the homeostatic sleep drive, and second is the circadian rhythm. So when the circadian rhythm is say conducive for falling asleep, as well as the homeostatic pressure or the sleep that is also high, at that point actually we fall asleep. And whenever there is a desynchrony between these two mechanisms, for example, somebody is trying to fall asleep in the morning or maybe in the noon, then they are actually going against the circadian rhythms, and that can lead to the inadequate sleep. So when I say here inadequate, that can be inadequate in the quantity as well as the quality. And such discrepancies, because the sleep is not refreshing when when we are sleeping at the odd times, so that lead to the neurobehavioral impairment. And these neurobehavioral impairment, especially the problems with this the concentration, problems with the memory, so they can actually lead to certain kind of the troubles in our life, and they can also give rise to certain accidents. Now, when we talk about the sleepiness, we usually talk about the sleepiness during the day. We usually do not talk about the sleepiness in the night. So sleepiness can happen, or what we call say daytime sleepiness, because most of us follow the normal circadian pattern. So daytime sleepiness can result from either sleep deprivation or sleep restriction. Well, many a times these two terms are used interchangeably, but they are not interchangeable. So sleep deprivation means there is a period of extended wakefulness beyond 16 to 18 hours. And if we look at the sleep restriction, that usually means that you are not taking adequate amount of sleep, and this goes on again and again. So sleep deprivation means because of certain reasons, say I have to socialize or I have to prepare for an exam, and I'm not sleeping the whole night, and the next day I'm appearing in the exam. While the sleep restriction means that because of the increased workload or because of the socialization, suppose I need around 8 hours of sleep every day, and I'm cutting down my the sleep by 1 hour. So now I am taking just 7 hours of sleep every day. So that is sleep restriction. That is, so these two terms are different. And when we talk about the sleepiness, may I request all the participants to please mute themselves?
Okay, okay, thank you, thank you.
Okay, so when we talk about the sleepiness, that usually results in the wake state instability, and that is the reason that the people who are sleepy, they have intrusion of the micro sleeps in their waking period, And when the sleepiness continues to continues to be prolonged, then rather than the micro sleeps, they may actually have micro naps, or then naps lasting few minutes in their wakefulness. So that leads to the instability in the state of wakefulness. Then when we talk about the sleep restriction, that usually leads to two different kind of errors. One is the errors of omissions. That means something which which we are expected to do and we are not doing it. For example, we are driving a car and we need to apply the brake and we are not doing it. So that's the error of omission. And then there are error of commissions. For example, we are driving a car and there is a crossing, so we need to slow down, and we have to say put our pedal, put our foot away from the accelerator pedal, and we are not doing it. So that is the error of commissions. So both of these kind of errors, they are usually seen with the sleepiness. When we look at the sleepiness, there are different dimensions of sleepiness. So one of the way to measure the sleepiness is to grade it. For example, sleepiness can be lying on a continuum from absent to present. And of course, there is a gray zone in between, which we can say assess through various investigative technologies. So that is one way of looking at the sleepiness. Secondly, many a times in the experimental protocols, we make the people deprive of a particular sleep stage, so either non-REM or the REM sleep. So what we see after that, that during the rebound period, they have only the say greater proportion of the sleep stage from which they were deprived. So that is another dimension. And third is the sleepiness can be optional or it can be core. Core means it is present and it is a part of the physiological process, or at times because of the pathological process. And secondly, the sleepiness can be optional. For example, the people who are socializing, especially the teens, so they are restricting their sleep, and that leads to the sleepiness. In here, it is optional because they can actually lengthen their sleep period at night to um, uh, say get rid of the sleepiness during the daytime. Now, when we look at the neurobehavioral effects of sleepiness, so that leads to the lapses in attention, that leads to the slowing of the response, and that leads to impairment in the memory. Similarly, sleepiness also increases the decisions which involve risk taking. So the people they meet accidents. Sleepiness also increase the sensitivity to the pain, and that is one reason why many of the patients of the sleep disorder, they come and they present with the complaints of generalized body ache and pains, and sometimes they are misdiagnosed as somatoform pain disorder. Similarly, we all have come across the patients and their relatives who say that whenever they are very tired and very sleepy, then they start snoring. And this occurs because the sleepiness actually impairs the dilator response of the upper airway muscles in response to the hypoxemia and hypercapnia. So a sleep restricted individual having the sleep apnea would be having greater severity of OSA compared to the same person who is not having the sleepiness. When we talk about sleepiness, again, sleepiness can at times be physiological because we are either restricting the sleep or we are in a state of sleep deprivation. But we should always understand that sleepiness always does not present the way it is. For example, a person's, whether he is sleep deprived or is under the state of sleep uh, acute total sleep deprivation or the sleep restriction may be feeling sleepy, but that sleepiness will be modulated by the prior sleep duration. So if the prior sleep duration is adequate, so in the initial few days, person may not feel sleepy, and this sleepiness accrues after only say few days or few weeks. Then even when a person is feeling sleepy during the daytime, this sleepiness can be modulated by the presence of the family and the friends and the job's responsibility. I mean, we are aware of the medical students who are not sleeping for a couple of days or maybe even more, or who are restricting their sleep for even weeks together during the examination period. And it does not mean that they are not sleepy. The only issue is because they have other responsibility and which is motivating them, which is more exciting. So that is actually reducing the manifestations of the sleepiness. Then when a person is hungry or thirsty, definitely the body demands the water and the food, and during these periods of competing needs, the sleepiness is usually gone because the body is trying to engage in a behavior to find the food and the water. Similarly, even a mildly sleepy person may not be able to sleep well in a noisy environment or in an uncomfortable bed. But as the sleepiness increases in the severity, these environmental factors may not play a role. So if we look at the cartoon on the right side, what we can see that all these factors which actually modulate the sleepiness, so their role actually reduces as this severity of the sleepiness increases. So a person with severe sleepiness can fall asleep anywhere, but a person with mild sleepiness can actually tolerate their sleepiness in presence of the other factors that we have just discussed. Always remember, this sleepiness, even if it is mild, can always be unmasked by the monotonous activity. So whenever you are examining your patient for the presence of sleepiness, do not ask whether they are feeling sleepy during while watching the TV or while watching some kind of OTT platform or along with the friends, but ask them whether they feel sleepy when they are traveling and they don't have to drive, or maybe when they are sitting in a meeting which is quite boring, or to the students you can ask when they are studying or when they are sitting in a lecture. So that usually, because these are monotonous activity where the person usually does not have to participate much, so they can actually unmask even the mild form of sleepiness. When we look at the sleepiness, sleepiness can at times be physiological. We all know that there is an circadian rhythm of the alertness. So in the morning after waking up from the sleep, we are alert, and this alertness increases till noon. At around 12 noon, this alertness starts falling down and it reaches the trough at around 6 o'clock in the evening. So this period of the afternoon between 3 to 6 is the period when the people they are feeling sleepy, and that is the reason many of the people they enjoy siesta. After 6 o'clock, again there is an elevation in the arousal and the attention, which further declines at around our bedtime, so nearly 10 o'clock or so. And this arousal reduces, and this reduced arousal during this period helps us to maintain the sleep. So and if you look at the data from the vehicular accidents and the industrial accident, you would find that most of the accidents would happen during this period, that is in the night between 2 to 5 a.m. and also during the afternoon period. So these are two basic the physiological um, uh, periods when we are feeling sleepy, even when we are actually not sleep deprived. If we look at the sleepiness, what are the factors which actually affect the sleepiness? So these are the quantity of the sleep. So a person who is sleep deprived or who is having the sleep restriction, they will fall asleep easily. So that will affect the results on the MSLT. So that is the reason whenever we do the MSLT, we usually ask the patient to bring the sleep diary for past 15 days. Then there are individual differences in the response to the sleep restriction and sleep deprivation. For example, a person who is already sleep restricted prior to the sleep periods of sleep restriction that you are imposing, he will be more sleepy than a person who was getting adequate amount of the sleep before you started the periods of sleep restriction. Then there is an individual sensitivity and tolerability to the sleep debt. Certain people, they are very sensitive to the sleep debt, and so they develop sleepiness even in presence of a short period of sleep restriction. And certain people, they are who are able to tolerate the sleep debt, they may not feel sleepy even after the prolonged period of sleep restriction or sleep deprivation. So this sensitivity and tolerability is actually perhaps somewhere is dependent upon the genetic factors. May I request all the participants to mute their mics because this is the recording that we will be placing on the YouTube as well. Then second is the quality of the sleep. We all know that the people with the sleep disorders, especially the sleep apneas, the people who are suffering from sleep-related movement disorders and so on, they have fragmented sleep. So fragmentation of the sleep can be calculated by looking at the arousal index, looking at the shift to either N1 or to W from the other sleep stages, or looking at the time spent in the N1 sleep. So the people who are having fragmented sleep, they usually complain of non-refreshing sleep, and they usually complain of sleepiness during the daytime. And elderly, because of the increased risk of PLMD as well as the risk of sleep apnea, they are usually having the fragmented sleep, and that leads to the daytime sleepiness in the elderly. When we try to look at the different biological rhythms, except for that of the melatonin rhythm, what the studies have shown that it is only the temperature rhythm that coincides with the sleepiness. So people, they feel sleepy when the temperature is falling. So what happens in the night, that there is a gross fall in the temperature because of the environmental factors, because of the rest period, and that allows us to fall asleep. Similarly, there is also a fall of the body temperature during the afternoon. Of course, the magnitude of the fall of the temperature during the noon is lesser than that of the magnitude of the fall of temperature in the night. But yes, even that smaller fall during the noon period or afternoon period, that actually makes us feel sleepy and reduces the alertness. When we talk about the basal level of sleepiness, so this can be reduced by extending the sleep time. We all know, we all ask our patient who are sleepy to reduce their sleepiness by extending the bedtime. And if they are suffering from any kind of sleep disorder, we usually treat that, so which also improves the sleep quality and reduces the basal level of the sleepiness. One important part, we talked about the sleepiness in response to the circadian rhythm, and we looked in the first slide that the sleep is usually most refreshing when both the homeostatic factor and the circadian factor, they go hand in hand to promote the sleep. So the people, especially the shift workers, when they come back in the morning from their night shift and they are sleep deprived, they try to fall asleep. But even when they fall asleep during the daytime, their sleep is less refreshing than that of the nighttime sleep. And consequently, this daytime sleep, though it reduces the basal level of the sleepiness by, say, some amount, but the neurobehavioral improvement that should occur because of the sleepiness, that does not happen as much as it does when the person is sleeping at the night. And the only reason is that the person is trying to sleep, which is in a non-conducive circadian rhythm. We all know, we all advise our people who are patients who are coming with the narcolepsy to take the scheduled naps, and also we advise the people who are working in the shift to take the scheduled naps before they are going for the work, so that reduces the basal level of sleepiness. But again, you should understand that even when they are taking naps at the odd times during the day, the level of the sleepiness and the neurobehavioral impairment will not reduce to the extent as it would reduce with the nighttime sleep. Now, there are certain medications. So, if a person who is already having higher basal level of sleepiness, and if he takes the CNS depressant, for example, benzodiazepines or the alcohol, so that would be, they would experience an amplified effect of the benzodiazepine and the alcohol, both the substances which act on the GABA A receptor. But the basal level of sleepiness doesn't affect the response to the caffeine and methylphenidate. So no matter how sleepy a person is, but if you are giving the caffeine and the methylphenidate, the response will always be alerting. And the people who are having the basal level of sleepiness, they have increased risk of self-medication with the stimulant substances, especially which are socially sanctioned. So caffeine, nicotine, and maybe tea as well. So these people, I mean, any of the patient coming to your sleep clinic, and if he's consuming excessive amount of the caffeine or the tea or the caffeinated beverage, always think that person might be having certain basal level of sleepiness that he's trying to compensate by using these stimulants. When we look at the neural substrates of the sleepiness, so what has been found that the sleep deprivation reduces the blood flow in the prefrontal, inferior parietal, superior temporal, anterior cingulate, limbic, thalamus, and basal ganglia region. And we all know that these regions are important for certain cognitive functions like executive functioning, attention, working memory, which are all affected by the sleep deprivation, and they are impaired in the sleepiness. Similarly, anterior cingulate and the limbic cortex, they are important for the emotional management, and it is not uncommon to see our patients who are having sleepiness or those who are not having the refreshing sleep, they become too irritable or anxious during the day, and that is the reason that they are at greater risk of development of not only depressive disorders but also anxiety disorders and the substance use disorder. Similarly, thalamus and basal ganglia impairment, again, it might be related to the cognitive functions, not necessarily the motor functions. So this details we do not know, but we all know that the sometimes the gross motor functions are also impaired during the sleepiness, and thalamus is having the reduced function. That means it allows lesser amount of the stimuli from inside the body and outside the body to reach the cortex, and that actually affects the decision making as well. Now, default mode network is an area in the brain that is maximally functioning during when we are idle, when we are not doing anything. And as soon as we are engaged into any kind of the activity of the DMN reduces, and the activity of the areas of the brain which are responsible for the task in hand, they increase. So what has been found that in the people who are sleep deprived, they have increased activity of the default mode network. And there is also reduced functional connectivity of the default mode network. And this increase in the activity of the default mode network is similar to what we see during the N2 stage of sleep. And this suggests that the people who are sleepy, they are not, their brain is actually not processing much of the information and is mostly at rest. Then among the neurotransmitters, we have found that the striatal dopamine receptors, they downregulate, and the serotonin receptors, they upregulate, but exact clinical implication of the changes in the receptors is actually not known. This is just an observation as of now. After the acute total sleep deprivation, if your brain is engaged into some task, for example, you have been given a puzzle to solve. So what we would see that there is a reduced activation in the prefrontal cortex and the intraparietal sulcus. Again, the areas which are important for the attention and the concentration and the judgment. Then there is a reduced activation in the salience network, and this network lies between the medial frontal cortex and the insula. And that is the reason people who are sleep deprived, they are not able to enjoy any of the tasks. But there is an increased activation of the thalamus, which is perhaps secondary to the task given to the person, and probably it depicts the de-arousing effect of the sleep loss and also the arousing effect of the task performance. So in total, when a person is sleepy, we have actually now the through the functional brain imaging methods, we have enough data to say that the brain functioning is also altered. Now, why does a person become sleepy when he is sleep deprived or there is a restriction in the sleep? A number of theories have been put forward, but as of now, the most acceptable theory is that of accumulation of the adenosine in the basal forebrain. So once it accumulates in the basal forebrain, it inhibits the acetylcholine and the glutamate function, and we know that both these neurotransmitters, they actually keep our cortex working. It has also been found that when we are talking about the acute sleep deprivation, that usually leads to the increase in the adenosine level. But when we are talking about the sleep restriction and the chronic partial sleep deprivation, that leads to the changes in the receptor concentration of the adenosine. So mechanism of the acute versus chronic are not similar, and perhaps this is the reason that both the people, they take variable trajectories to resume their normal functioning when they are given the adequate opportunity to sleep. Similarly, the histamine receptors, the H1 and the H3, both have been implicated in the sleepiness and the wakefulness. And we all know that certain medications like pimoline, which work primarily on the H3 receptors, they increase the wakefulness, and certain medications, for example, cetirizine, which act on the H1 receptor, they make us feel sleepy. There have been certain medications which the orexin receptor antagonists, which have been proposed to as the hypnotic medication, but as of now, we do not know how much role the orexin or the hypocretin they actually play in the sleepiness. Yes, their role in the occurrence of the central disorders of hypersomnolence, that is the narcolepsy, is very clear. Similarly, the agents acting on the GABA receptor like benzodiazepines, they make us feel sleepy. So that is another target for the medications or the interventions that we plan to reduce the sleepiness in future. Now, one important thing to understand is that all the people, when they are deprived of the similar amount of the sleep time or even the similar proportion of the sleep period from their habitual sleep period, then all of them, they do not develop the sleepiness. So there are individual differences. And also during the sleep restriction, or also known as the chronic sleep deprivation or chronic partial sleep deprivation, there is an adaptation that occurs to the chronic sleepiness. So our brain becomes slightly more functional when we are doing some task, and that actually reduces the amounts of the error. Similarly, when you ask the people who are sleep deprived or who are sleep restricted, then you would find that they may not feel themselves to be sleepy, but when you do the objective testing, you would find that they are actually sleepy. So there can be a discordance between the subjective and the objective measures of the sleepiness. And this occurs because the neurobehavioral effects of the sleepiness that we talked about, the cognitive functions and other things, uh, they usually do not impair that much, because certain people are able to resist it because of the increased tolerability, and in those people the compensatory mechanism, they get initiated and they mitigate the cognitive and the behavioral effects of the sleepiness. So these are the reasons that there can be an individual difference, inter-individual differences in the same proportion of the sleep deprivation. Then different people say when they are exposed to the similar proportion of the sleep deprivation, so they all of them, they do not develop the similar magnitudes of the neurobehavioral impairment. It has been found that the neurobehavioral impairment which occurs after the sleep restriction is not related to the personality or the IQ or the baseline scores on the performance test or the habitual sleep duration. So there are multiple factors which might be responsible, but what are those factors we do not know. But what has been found, that though there are inter-individual differences, but the intra-individual differences are not much. So a person who is having, say, neurobehavioral impairment after a sleep loss of 1 hour for every day for 5 days will have a 10% impairment on task A. And if you allow him to get the recovery sleep, and after the recovery sleep, if you all again expose him to the same kind of impairment, he would again be having the similar magnitude of the impairment. So the neurobehavioral responses after the sleep deprivation or the restriction are very specific to a given individual, and they usually act as a trait marker of the sleepiness for that particular person. So what does that mean? That the available tests, whatever you are having, though they may not be able to differentiate between the sleepiness and the normal sleep, but between the individuals or among the individuals. But yes, for the test to retest, you can always comment reliably on the at two different time points, whether at one point of time the person is sleepy or not. And this is usually regulated by the genetic factors which are still under research. Now, um, we have talked about the individual differences. So what has been found, that the people who are resilient to the neurobehavioral impairment that occurs in response to this sleep deprivation or sleep restriction, they have increased parietal activation during the performance lapses. Friends, we already discussed that the people who are sleep deprived, they have reduced activation of the parietal cortex. But these people who are resilient, they are probably resilient to this effect as well. Then the people who are resilient, so their blood flow in the other brain areas, for example, the frontoparietal regions and the basal forebrain and the anterior cingulate, is also either maintained or increased even when they are under the state of sleepiness, and that is the reason that their neurobehavioral performance does not impair as much as the people, those who experience reduction of the blood flow or the activation of these areas. Coming to the core question, whether sleepiness can be equated with that of fatigue. So if we look at the fatigue, so it is classically defined as the lack of motivation and the energy, and the fatigue can be physical, can be mental, can be emotional. And to assess the severity of the fatigue, what we need to look at is the latency between the initiation of a task and the point where the performance start degrading. So greater the fatigue, lesser the latency between the onset of the task and the decline in the performance. Similarly, sleepiness is can be best defined as desire to fall asleep. So a sleepy person would say, look, I want to just sleep. But a fatigued person would say that, look, I don't want to fall asleep, but I just want to take some rest and I don't want to do anything. But usually they go hand in hand, and both of them, they increase the risk of the lapses and the errors and the slowing. When we talk about the sleepiness and its measurement, so there can be three different ways where the sleepiness can be measured. One is the introspective, that is the self-reported measures. Then there can be a physiological measures which affect the sleep onset latency. And third is the manifest sleepiness, where you actually see the gross behavioral or performance deficits. So we will examine each of them one by one. But before we start with the assessment of the sleepiness, we must know certain basic concept. First of all, it is very difficult to assess the sleepiness, at least quantitatively, because few quantitative tests are available. We have already seen that the quantitative tests, for example, those tests of performance, they might be having interim individual variation, even in the presence of sleepiness. So they are good to compare the intra-individual differences across time, but we don't have the normative value available for them. And that is the reason, based on any of the tests, we cannot say whether the person is sleepy or not. Then, second more important issue is whether you are assessing the sleepiness for the clinical reasons or for some kind of legal issue, which may include either compensatory or the regulatory purpose. So we know that the performance test would be impaired among the person who are seeking compensation because of the arising out of some error due to the sleepiness, because they may not put their best effort, so there is lack of motivation, and that would lead to increased amount of errors. Similarly, when you are doing MSLT in the people who are seeking employment, so they don't want to show that they are sleepy, so they can always ignore your command, allow yourself to fall asleep, and that is the reason they try to stay awake, and because of that motivation, their sleep onset latency may be delayed. Similarly, when we look at the other tests, people who are seeking compensation, they may exaggerate the self-report of the sleepiness, while those who are seeking employment, they can actually attenuate the severity on the self-report measures of the sleepiness. Then another important issue is the metric validation. We all know that the sleepiness is having a circadian variation, or in other words, we can say the opposite of the sleepiness, that is the vigilance, is having the circadian variation. So the amount of the magnitude of the sleepiness that you are measuring at say 10 o'clock in the morning may not be similar to that of 4 o'clock in the evening, or may, for that matter, may not be similar to 2 o'clock in the night or 4 o'clock in the morning. So that is another issue, that when you are measuring the sleepiness at a particular time, you cannot extrapolate that result on the sleepiness that can occur on the other circadian period. So whenever you are preparing the report of the MSLT, you have to be very cautious. Do not give a quantitative report looking at the 5 naps, but also mention that during the natural circadian dip, whether the person was sleepy or not. Now, when we talk about the introspective measures, there are number of measures. Among these, two of the most commonly used are the ESS and the Triple S. So effort sleepiness scale does not measure the sleepiness, but it actually measures the propensity to fall asleep under different conditions. On the other hand, the Stanford Sleepiness Scale and the Karolinska Sleepiness Scale, they measure the sleepiness when you are actually testing the person. So you ask the person to put a check mark how sleepy that person is feeling at that particular moment. When we look at the physiological measures, we have the MSLT. So we have two different protocols for the MSLT. But before doing the MSLT, we need to have a sleep history of past 1 month that includes the sleep wake period and sleep wake schedule. We need to have a prior night polysomnography so as to rule out other sleep disorder. And we usually start it 2 hours after the morning waking. We usually give 4 to 6 opportunities at the interval of 2 hours where we ask the person to allow themselves to fall asleep in a calm, quiet, dark environment, and we wake the person after a period of unequivocal sleep. Now, what do we mean by unequivocal sleep? For the research protocol, we say unequivocal sleep means 3 N1 epochs or 1 epoch of either N2 or N3 or REM. Now, this is a slight difference when we wake up the person between the research protocol and the clinical protocol, because in the clinical protocol, we allow the person to stay asleep after the first for 15 minutes after the first epoch of the unequivocal sleep. And the reason is we want to see here, for the clinical reason, we want to see the sleep onset REM. But in the research protocol, since we are just measuring the sleepiness, so we wake the person up because we don't want him to take 15 or 20 minutes in the nap and get reduce the sleep debt. In both the protocols, if the person is not able to fall asleep, we terminate the test after 20 minutes. Now, in another measure is the maintenance of wakefulness test. And for this test, because we are primarily targeting the ability to stay asleep in a controlled environment, so we do not need any kind of polysomnography prior to the MWT, or we don't need even the prior sleep history. And this is usually done for the purpose of the employment. So we start the test similar to MSLT 2 hours after the morning waking, and we give 4 trials at the interval of 2 hours. We ask the person to put their best efforts to stay awake, and we wake the person after he gets the unequivocal sleep. That means 1 epoch of either N1, N2, N3 or REM. If the person doesn't get the sleep, then we terminate the test after the 40 minutes period. Now, when we look at the MSLT, it usually looks at the chances of falling asleep. So it is similar to the Epworth sleepiness scale, and it identifies the maximum risk. So there can be people who are trying not to fall asleep even during the MSLT, but if they fall asleep, that means they are at even greater risk to fall, and they are having enough sleepiness which can even take over their motivation to stay awake. On the other hand, when we talk about the maintenance of wakefulness test, we are testing the ability to maintain the wakefulness. But the only problem is that when we are doing the test in the lab environment, that environment is not similar to the environment in which the person actually works. And we have seen in the earlier slides that there are a number of factors which can actually modulate the sleepiness, the social factors, the emotional factors, the cognitive factors. So we are not sure when in the absence of these factors, the person is able to maintain the wakefulness or may not be able to maintain the wakefulness. But when the person is actually working in his real life, so in presence of these factors, whether he would be able to maintain the wakefulness or not. So that is one of the shortcomings of maintenance of wakefulness test. Then there are other physiological measures which can be used. So what happens usually when we fall asleep, the pupil usually constrict because of the increased parasympathetic activity. And the magnitude and the speed of constriction in response to the light also slows down when we are asleep, and the pupil become of unstable size because of the changing sympathetic and parasympathetic response. But the problem is this technology is very difficult to measure, because usually whenever the person falls asleep, they close their lids. Then there are inter-individual differences are difficult to find out, and that is the reason we don't have the normative data. So again, like like other tests, it can be used for the individual intra-individual differences at 2 points, but cannot be used for the inter-individual differences. There have been efforts been put to develop the EEG based detection machines which can detect the sleepiness. So these equipment, they use the spectral power densities and EEG usually in response to a stimulus. But the problem is, again, there are inter-individual differences are difficult to find out, and we don't have the normative data. So that is one of the limitation. Whether the event-related potential also are affected by the sleep deprivation, that is an area where we need to work at. Similarly, for the physiological measures, we should work towards finding the certain biomarkers which can actually quantify the level of sleepiness. So that would be, if we are able to find out such a marker, so that can actually help us to reduce a number of vehicular as well as industrial accidents. Then we can also see the manifest sleepiness, that is the gross behavioral changes that occurs with the sleepiness. So the common changes that we see is the head bobbing and the ptosis. But the problem is both these changes, they are not very specific to sleep. For example, ptosis you can see in the myasthenia gravis, and the head bobbing you can see in the CLD, as well as especially the CLD with the liver failure, and as well as the third ventricular SOLs. So that is the reason these measures are not quite robust, and they can at times give us the wrong idea about the sleepiness. Then coming to the performance test, and we have already discussed that the long monotonous tasks are usually most sensitive, and that is the reason that number of studies have been done to assess the sleepiness, and they employed different kinds of tests, but each of these studies they found a different result. And it is because usually these tests are not long and monotonous, and that is the reason there is an amount of the motivation that comes in the play, then amount of excitement that comes in the play, and that can take away the sleep. That can actually lead to the over performance on the test, even if in a sleepy individual. But one exception is the 10-minute psychomotor vigilance tests, and this has been found again and again that psychomotor vigilance test is actually very sensitive and specific to the sleepiness and the fatigue. And if you look at the number of lapses, they actually increase among different individuals in response to the number of hours awake. Now, this psychomotor vigilance test, its results are not confounded by the learning effect and the aptitude because it works on the variable period method. So the person gets the stimulus to give a response at varying times. So he has to actually keep a sustained attention. And this has the ecological validity because the sustained attention or the concentration is important for the safe driving as well as good learning. Now, coming to the legal aspects, what I have come to know that only US has certain laws regard to prevent the sleepiness and to minimize the errors. Of course, there can be certain laws in the Indian labor law, but I think we need to look at that. So these laws, they are different laws for the maritime, for the trucking industry, for the railroad industry, for the aviation industry, and for even for the medical residents. And all these laws, they forbid the continuous working or the sleep deprivation beyond a certain limit to so as to reduce the chances of the errors and accidents. Now, when we talk about the recovery from the sleep deprivation, it depends upon the number of factors. So the recovery from the acute sleep deprivation is usually quick, while that from the chronic sleep deprivation usually takes time. Now, one of the important issue is that the duration of the recovery sleep, that is how much time a person is spending in a recovery sleep, whether the 8 hours or 10 hours or 12 hours, that usually is having a ceiling effect on the neurobehavioral performance. So, the neurobehavioral performance, suppose it may improve to the same magnitude even after the 8 hours of recovery sleep. And here it may be ceiling. So even if the person is sleeping for 16 to 18 hours during the period of recovery, the neurobehavioral performance would not improve. So that is something that we need to understand. Then it also depends upon the number of days for the recovery. So greater the sleep deprivation, greater the number of days for recovery are required. And the number of days are important because there is a ceiling effect to the duration of the recovery sleep. When we look at the performance at the on different neurobehavioral tests, after the recovery sleep, people, they have different performance across different tests. And also there is a discordance between the subjective and the objective measures of the sleepiness after the recovery sleep. So there might be a possibility that person might not feel sleepy even after the adequate recovery sleep subjectively, but the objective measures may mention that the person is still sleepy and require more recovery sleep. So this is all for today, friends. So we talked about the concept of sleepiness and the fatigue. We talked about the neural aspects of the sleepiness and the fatigue. Then we looked at why the people they have differences in the sleep in response to the sleepiness, and we looked at the legal aspects, and finally we looked at how much recovery sleep do we require. So this is all for today. Thank you very much. And if there is any question, I'll be happy to answer.
Sir, can you please tell about the repeat about that concept of metric validation?
Yeah, metric validation means suppose you are assessing the sleepiness of a person at a particular time of a day, say 10 a.m. So result of this assessment at 10 a.m. cannot be extrapolated to other times of the day. For example, 2 p.m. or 6 p.m. or 10 p.m. or 2 a.m. and 4 a.m. because there is a circadian variation in the alertness, and so is the circadian variation in the sleepiness. So
Yes,
a
sir. Yes, sir.
person might not appear sleepy at 10 o'clock in the morning, but may report sleepiness at 2 o'clock in the afternoon.
Yeah.
So,
Understood, sir. Thanks.
so the test result would vary.
Right, sir.
Okay. So there are two questions in chat box.
Okay, just a minute. Okay, so 4 to 6 naps means usually we give 5 naps, and the only issue is that we need to look at the sleepiness across the daytime. And we follow the same policy of that of ASM. We go with the ASM recommendation for conducting the MSLT. Of course, we don't do the MWT because we have not got the recommendation so far. But for the MSLT, we usually follow the ASM recommendation. We give 2 hours of gap because we want to look at the sleepiness as a function of the circadian time throughout the day. So I hope I have answered both the queries. Thank you, friends, for joining, and maybe we will meet again and we will share the next schedule soon. Thank you very much for joining. Have a good day.
Sir, good
Yes,
morning,
sir.
sir. This is Lata one more time.
Yeah.
Sorry. I was just wondering, would you be able to share your lab policies and procedures? Only because I just wanted to see the similarities that exist here and overseas.
Sure.
I would love to review and see
Okay.
how they are different, because I already saw that the NAP opportunities for MSLT are 4 to 6.
Yeah.
And I mean, I would love to see the oxygen policy and probably the split night and ESG and all that.
Sure.
If you would share, I would really, really appreciate it.
No, definitely, definitely we'll share our lab policy.
Yeah, and I'm also actually automating the worksheet for the technologists. So if you're interested, we could discuss that some other time.
Yeah, sure. That will be very great.
Yes, sir. Thank you, sir. It was very, very illuminating.
Thank you. Thank you, friends, and have a good day.
Thank you, sir.